Hi, my name's Anna Marie Piquereau, and I'm going to be talking about my rotation experience at the Bruggeman Center. So the Bruggeman Center is located at Ellis Hospital, Knott Street, and it is located on the first floor of the A wing. So the staff is primarily made up of registered nurses, a gastroenterologist, and a nurse anesthetist. The function of the department is to do screenings such as colonoscopies and endoscopies, basically with an endoscope going through the gastrointestinal system and check for any polyps or abnormalities within the system. So this department interacts with oncology, the surgical floor, and radiology. Oncology because if cancer is found or if a patient has pre-existing cancer, they can be sent there for a more thorough procedure or examination. The surgical floor can take care of removing any large tumors that can be found in the gastrointestinal system or attempt to remove tumors that can be removed. And radiology department because the radiology department can detect any issues within the gastrointestinal system. For example, while it's in radiology, a patient was told to consume a certain drink so that they could see how it goes through the gastrointestinal system. And if an abnormality is seen with that, they could do a thorough exam in this department in the Bruggeman Center. Next, I'm going to talk about my observations in the Bruggeman Center. So they gave me this nice little diagram. This is of the large intestine, the colon, and basically it shows how the parts of the colon, so when the endoscope goes in for the colonoscopy, it'll go through the rectum, sigmoid colon, basically in reverse, and here's the appendix, and it's basically like a little piece that hangs off of the colon, and sometimes bacteria can gather in there and it can get inflamed or burst, and that's why people have their appendix removed, appendectomy. Okay, they also gave me this diagram of the pancreatic system. So this is the gallbladder, the pancreas, and yeah, and it dumps bile into the duodenum here. So it just basically shows you how that works, and with their endoscope they can examine this area as well. Here's the diagram. Alright, so the patient coming in has to do some prep themselves, and that's just to clear their colon or their esophagus. So if a patient is coming in for a colonoscopy, they will typically take a certain laxative that will clear their system, and they're only told to eat certain food for a day, and typically that's like Jello or something that's sugary, just to give them energy. And that's like the prep, and that's so that they could see the walls and do a good examination, also so that it doesn't smell, it's not messy for the doctor themselves. All right, another procedure. Alright, I also saw while I was there EGD, which is a esophageal-gastro-duodenoscopy. That's a very hard thing to say. But basically, it examines the esophagus, stomach, and duodenum with a flexible endoscope. Right? The patient under both of these procedures is put under a light anesthetic, so it's basically like they're sleeping. It's not the same anesthetic that would be in surgery, and sometimes they can wake up during the procedure, but they typically won't remember it because of the medication. And basically, they gather medical history to see if the patient has any problems with certain types of meds, and that's because they are going to be put under the light anesthetic. All right. And the endoscopy itself, the instrument, basically it has like a camera at the end, and it's like a flexible tube, and with controllers he can maneuver how it turns, so that if he inserts it here, he can maneuver the tip, and then it could like go in this direction. And that's how he kind of the doctor would wind it up and in through the colon and examine different parts In addition, there's like this hollow tube part where he can insert any instruments like clippers. For example, when there's a polyp, he can loop around the polyp and clip it off or grab it off, and he could also insert clippers, and sometimes if there is stool in the way, he can wash that out using the instrument. And it's basically a very non-invasive procedure and can remove polyps and other substances to a certain extent. Alright, I'm going to start talking about some of my patients. So there was an elderly man there who had recently broken his hip, but there were some concerns about his large intestine, so he was called in for a colonoscopy. They had to be very careful with him because of his broken hips. He was elderly. So when they started doing the procedure, they did notice that he didn't prep properly, but the colonoscopy was urgent, so they proceeded with the procedure despite him not having prepped. So it did smell really, really bad in the room. The nurse actually went out to grab some Febreze disinfectant. It was like kind of like staying in the room because the doors were all like closed. Not my best experience. Smelled really bad. I really wish I had a mask for that one, but that was the first procedure I saw, so it really didn't set a good tone for the rest of the rotation. But moving on from that one, I did see a EGD. That case was really interesting because he did work a lot with the pancreas, and he did a lot to examine that area as the patient had a history of issues, and the patient was under a light anesthetic as well for that procedure. It is a little different. I personally found that procedure very interesting, and during the procedure I did notice like these little white things, and I did ask what they were, and it was apparently an undigested pill, and it just looked so different from what you would think it would look like. I thought it was like a foreign substance or something. But I really liked the EGD a lot better than the colonoscopy. It's just a lot cleaner, and it's kind of cool to see the anatomy. You could see the rugae inside the stomach, which is basically like all the wrinkles. It's kind of cool. But another procedure I saw was a routine screening, and it was for a male. They did remove 2 polyps, but he had a history of being clean, and it was his last routine colonoscopy because of age. I also saw another routine female colonoscopy, and basically they only removed 2 polyps, and it was unneeded. They didn't need to loop around it and cauterize. If in that part of the video I seem very broken up, that's because I ran out of storage. But going back to what I was saying, this patient didn't need to have the polyp be looped around and cauterized just because it was so small. He actually just clipped it off. There wouldn't be too much bleeding enough that it would need to be cauterized. So they removed the polyps for her. And after that, I actually got to see a really interesting case. It was someone who had esophageal cancer, and she had actually developed a tumor that had metastasized to other parts of her body. And she hadn't been responding well to chemo, so she was having this EGD just to give her an examination to see her overall progress. And while we're going through the EGD and she was all prepped, it actually started off pretty normal. There was no look of abnormal growths, but once we got closer to the stomach, I did see a tumor that looked very unusual. It wasn't very consistent with the growth. There were like little sprouts coming off it. It was very out of shape, which are signs that it was cancerous. And they didn't really see much progress at all. So I was told by the doctor that they predict that she won't have much time to live, which is a very sad thing to hear, but especially because she didn't respond well to the chemo. It was also really interesting to see what cancer looked like. They told me that the surgical floor would be able to remove that, but since it metastasized, there wasn't really a point at this stage. They couldn't remove that in the Bruggeman Center just because of the size of it. They could only remove like smaller polyps. So yeah, the beginning of my rotation was not my favorite case just because of the odor. I'm not very good with odors. It was very strong. However, I really did like the EGDs and seeing the gastrointestinal system. It's also really interesting to see the stomach and on the rouge, and it was just really cool to see a procedure. I really like the anatomy side of medicine. So for advancements within the Bruggeman Center, I would say most of the advancements are with the endoscope instrument used for endoscopies and colonoscopies. So it's continuously advancing the technology that they use, and the endoscope instrument itself has many capabilities, and this can enable us to prevent invasive procedures because it has a lot of capabilities. Like it can remove polyps and cysts, and it can clip foreign tissue and take biopsies. And basically it has a camera at the end, an area that water can run through so it can wash out any abscess stool, and it has a narrow opening for instruments to be run down. And it continues to advance. It's made out of optic cables, and basically it's very special medical grade material, and it's very advanced technology as the end can move with a controller. And such technology continues to advance as we are in the medical community gearing more towards less invasive procedures. So this is another thing that prevents us from needing an invasive surgery with a high risk of infection. So this has much lower complications, and we're gearing towards this type of higher technology. I'm now going to talk about some of the education required to work within this department. So as I mentioned earlier, the department is primarily made up of a gastroenterologist, a nurse anesthetist, and a registered nurse. So I'm going to start by talking about a gastroenterologist, and since they're technically a physician, I got my statistics online from what a general physician requires in terms of education. Alright, so they require a bachelor's degree, and after the bachelor's degree, they go on to medical school, and that takes 4 years to complete depending on their specialty, and it can be 3 to 7 years of an internship or a residency program. And they're required a particular number of continuing education credits to remain certified, and this is particularly around 50 a year, and this can be gained from lectures, online courses, or classes. Alright. Now, in order to become a nurse anesthetist, one must be legally licensed by their state to work, and they have to have at least a master's degree and earn national certification. And in order to maintain certification, a nurse anesthetist must also complete a certain number of continuing education credits, and this is typically 40 a year. Alright. And now I'm going to talk about the education it takes to become a registered nurse. So they must begin by having a bachelor's degree in science or nursing, and after having graduated a nursing program, students must pass a national examination to become a registered nurse, and the exam measures a nurse's general knowledge of nursing and nursing concepts. And the annual continuing education credits required depends on how often the nurse works, so whether they're full-time or part-time. So it can really vary, but for certain workers I saw around 30 every 2 years, but it really depends on how often they work. I'm now going to talk about some of the economics and government associated with the jobs in the Bruggeman Center. So I'm going to begin by talking about a physician, and they make approximately 208,000 each year, and there are approximately 756,800 employed in the field, and this is expected to increase by 7% over the next 10 years, which is faster than usual, and an employment change of around 55,000 employees. All right, now I'm going to talk about a nurse anesthetist, and they make around 113,000 a year, and the job outlook is expected to increase by 26% over the next 10 years, which is much faster than average, and it's an employment change of around 62,000 jobs. Very big number. All right. And nurses are paid around 47,000 a year, and there are currently around 112,000 employed in the field. And there is a 7% expected job increase over the next 10 years, and this is approximately 9,700 jobs, which is faster than normal. All right, I'm going to talk about some of the jobs available for physicians, nurse anesthetists, and registered nurses in the public sector. So there are jobs for registered nurses in a school setting or the military setting, and for physicians and nurse anesthetists, there are jobs for them in the military setting, which is part of the public sector. And in addition, for nurses and physicians, there could be jobs available in the prison setting as well, which is part of the public sector. For my connections portion of this rotation, I am seeking an expert in the field. Name is Queena, mother of Annika Nielsen, over here. She's worked in the department. I am here with a medical professional who has worked in the Bruggeman Center. Care to introduce yourself?
My name is Gina Nielsen. I'm a nurse at Ellis Hospital.
All right, I'm going to ask her some questions. So, what do you think is the importance of colonoscopies and endoscopies and screening internationally?
Well, I believe it's important to be screened because I've seen so many people that are afraid to have colonoscopies, and it turns out that they have cancer because when you have symptoms, often, of nausea, vomiting, stomach pain, a lot of times it's too late and the cancer is spread elsewhere. So it's a choice of going to sleep, taking a nap, you're under anesthesia, you don't feel anything, and if there's any cancer there, it can be taken care of. A lot of times it's early stage cancer. Or you can choose to not to have your colonoscopy and have cancer that has spread, which could have been taken care of at an early stage, or end up with a colostomy bag or worse.
Yeah.
Mm-hmm.
All right. Do you have any personal experiences or stories you care to share?
With, in terms of interesting stories, Anne-Marie?
Yes.
Yes. Okay. So one time we had this lady come in, and she was having very bad abdominal pain, and she didn't know why. So it was an emergency. So off we went to look down her throat. So we did an upper endoscopy, and we went down her throat, and we found a pen. So full-size pen in there, the shaft, no ink, inner ink. It was just the pen shaft, the full length of the pen. So it was very hard and stressful for the doctor to try to retrieve it without doing any damage. So everybody came into the room, and then when we were done with the procedure, we did retrieve the pen, amazingly enough, without doing any damage. Very skilled doctor, Dr. Cornish, did a good job. But when the lady woke up in recovery, she had no idea how the pen got there.
That's crazy.
She didn't swallow any pen.
That's very interesting.
Mm-hmm. Yes.
All right. How would you say the reality of the Bruggeman Center would differ from a TV show or a movie?
Well, of course, the movies, everything goes smoothly. I've seen endoscopies in the movies where everything lasts about, 10 seconds or 20 seconds. They can, diagnose everything immediately from the endoscopy, which a lot of times doesn't happen because everything has to be snipped off and sent to the lab a lot of times, right?
Correct.
Mm-hmm. Here comes Annika.
Here comes Annika.
Yeah, I haven't seen too many endoscopies or colonoscopies on television.
Yeah. All right, and how this rotation relates to me is my grandma had colon cancer because she did not want to get a colonoscopy, and a lot of chemotherapy and pain could have been prevented if she had gotten her screening.
At 50, yeah.
At 50. All right, and in order to broaden my knowledge, I am going to read the gastroenterology journals by MD Links. I overall enjoyed my experience at the Bruggeman Center. Beginning, there was a patient who didn't prep, so I would say that was my overall least favorite part of the rotation, as the room did smell very bad, but it was interesting to see procedures done other than surgery, and particularly minimally invasive procedures with little or no complications. What would you say the hours are like in this department?
Well, when I worked there, I worked per diem. So I worked 8 to 4, and 7:30 to 4. But then there's 10-hour shifts and then there's 12-hour shifts. And one of the reasons I did not consider a part-time or full-time position there is because the nurses have to do call. So you can get woken up at 2 in the morning for a GI bleed and end up in a procedure with Dr. Cohen at 2 in the morning. GI bleed. I said, nah, no thanks. I'll be per diem. Thank you.
All right. Now, personally, I wouldn't work in this field just because I am more interested in other aspects of medicine, such as the laboratory and the surgical floor. However, I did have an overall enjoyable experience in this department.